All right, guys. Good morning. Nancy, I sent you a message. All right, so we're going to go and get started. I believe you were supposed to be doing the odd number questions for the Chapter 6 study guide. So we're going to get started on that. All right, number 1, true. Number 3, false. Number 5, false. Number 7, false. Number 9, true. Number 1, false. Number 3, true. Number 5, false. Number 7, false. Number 9, true.
I'm sorry, what is 161?
Which one was what?
Are we on page 161?
It should have been
215 to 220.
yeah, 215 to 220.
Okay. Then I did the wrong one. I don't know what I was thinking.
It's okay. Okay, key term assessments. Number 1, L. Number E, I'm sorry. Number 3, E. 5, C. 7, G. 9, F. 11, B. 13, K. All right, word parts. You should have 2 answers. 1, without. 3, state of. 5, instrument to measure. 7, vision. 9, to view, to examine. 11, pertaining to. Number 1, sclera. Number 3, light rays are focused on the retina and transmitted to the brain to be interpreted. 5, acuteness or sharpness of vision. 7, corrective lenses such as eyeglasses and contact lenses, laser eye surgery. Number 9, A, ophthalmologist. An ophthalmologist is a physician who specializes in diagnosing and treating diseases and disorders of the eye. An ophthalmologist is qualified to prescribe ophthalmic and systemic medications and to perform eye surgery. B, optometrist. An optometrist is a licensed primary health care provider who has expertise in measuring visual acuity and prescribing corrective lenses. An optometrist can also diagnose and treat disorders and diseases of the eye and prescribe ophthalmic medications. C. Optician. An optician is a professional who interprets and fills prescriptions for eyeglasses and contact lenses. Number 11, preschool children, non-English speaking people, and non-readers. 13, hyperopia and presbyopia. 15, a polychromatic plate consists of primary colored dots arranged to form a numeral against a background of similar dots of contrasting colors. 17, to treat eye infections, to soothe an irritated eye, to dilate the pupil, and to anesthetize the eye. 19, to lubricate and protect the ear canal. 21, pearly gray semi-transparent membrane. 23, to maintain equilibrium. 25, obstruction in the external ear canal, impacted serum, swelling, foreign body, benign growth such as polyps, fluid, serious otitis media, or infection, acute otitis media, in the middle ear, a perforated tympanic membrane, and osteosclerosis. 27. It provides information on the extent of hearing loss and which frequencies are involved. 29. To cleanse the auditory canal to remove serum, discharge, or a foreign body. To relieve inflammation by applying an antiseptic solution and to apply heat to the ear. 31. First, soften the serum by installing warm mineral oil or hydrogen peroxide. Next, perform an ear irrigation. Okay, so make sure you send me your responses. Okay. All right, so what did everybody think of chapter 6? What did y'all think of the worksheets?
I didn't really like this chapter.
Didn't really like this
Not that I don't like it, I couldn't really like focus on it. Do you know what I mean? Like it's all the other chapters, at least something has like stuck in my head, but this one, like I really could not just keep it in. Like I just couldn't focus on it.
Yes. Yep, I agree. It's a different chapter. It is one that once you are actually in the field, some of this, it will come back to you. You'll be surprised at what does actually stick. But yeah, it's a unique chapter. You know, it's not one like your medications or injections chapter. You know, this one's a little non-fun one, so to speak. But it is good. Okay, so I believe everybody on here, I have received your chapter 5 study guide questions, all but one person, and I've already messaged you. All right. So now let's go to chapter 8 on page 235. Chapter 8 is the gynecologic examination and prenatal care.
Miss Daniels, I don't have any messages.
Look on here.
Even I'm noticing like I can't see anybody that's been messaging, like I can't see nothing, like y'all's conversation, nothing.
Even on WebEx?
Yes, ma'am.
Okay, you should. Can you hover over the chat box and see if it tells you like a little red dot?
No. No.
Okay, what about remind?
No.
Okay.
Okay, I see it now.
Okay. All right, very good. Okay, so let's see here. Alicia, go ahead and start us off with the introduction to the gynecologic examination and prenatal care.
The medical assistant should have knowledge of gynecologic and obstetrics
Yes.
to assist in the examinations and treatments in these specialties. Gynecologic examinations are frequently and routinely performed in the medical office. Prenatal care consists of a series of scheduled medical office visits from the promotion of the health in mother and the fetus during the pregnancy. Obtaining the patient's cooperation makes the gynecologic and prenatal examination proceed more smoothly and as a result makes the patient feel more comfortable. The medical assistant can help by explaining the purpose of the procedure to the patient. If the patient understands the beneficial results to be derived from the examination, she is more likely to participate as required. This chapter discusses the gynecologic examination and prenatal care and the procedures involved in both.
All right. So before we even get started, what do we think this chapter is going to be talking about? When we think gynecologic and obstetrics, what do we think that's going to consist of?
Examinations,
Prenatal?
Yes.
pap smear, breast examinations,
Yes.
I mean, pretty much everything to do.
Well, yeah. So this is going to go into a more in depth on
Yeah.
what consists of, our womanly visits, our prenatal visits, so it's gonna go a little bit more in depth. All right, very good. All right, Anna, can you go ahead and read the first paragraph on the gynecologic examination?
I sound like a man in the morning. I'm sorry.
It's okay.
Gynecology is the branch of medicine that deals with the disease of the reproductive organs of women. The gynecologist examination is frequently and routinely performed in the medical office and generally includes a breast examination and a pelvic examination.
Very good. Okay, so you're going to highlight the first sentence and where it says includes a breast examination and a pelvic examination. All right. Jasmine, can you go ahead and read the next paragraph, please?
Where it says the purpose of, right?
Yes.
The purpose of the gynecologic examination is to assess the health of the female reproductive organs to detect early signs of disease, leading to early diagnosis and treatment. This examination may be part of a general physical examination or it may be performed by itself. Although assisting with the gynecologic examination is a routine procedure for the medical assistant, the patient may not consider it a routine examination. To reduce apprehension or embarrassment, the medical assistant should fully explain the procedure to the patient and offer to answer any questions.
Very good. Okay, so on page 235, you're going to highlight the first sentence in that second paragraph. All right, terms related to gynecology. The medical assistant should have a thorough knowledge of the female reproductive system and the following terms associated with the female reproductive system. Amenorrhea, absence or cessation of the menstrual period. Amenorrhea occurs normally before puberty, during pregnancy, and after menopause. Cervix, the lower, narrow end of the uterus that opens into the vagina. Colposcopy, examination of the cervix using a colposcope, a lighted instrument with a magnifying lens. Dysmenorrhea, pain that is associated with menstrual period. Dyspareunia, pain in the vagina or pelvis experienced by a woman during sexual intercourse. Dysplasia, the growth of abnormal cells. Dysplasia is a precancerous condition that may or may not develop into cancer. Menopause, the permanent cessation of menstruation, which usually occurs between the ages of 45 and 55, with an average age of 51. Menorrhagia, excessive bleeding during a menstrual period in the number of days, the amount of blood, or both, also called dysfunction uterine bleeding, DUB. Metrorrhagia, bleeding between menstrual periods. Perimenopause, before the onset of menopause, the phase during which a woman with regular periods changes to irregular cycles and increased periods of amenorrhea. Perineum, the external region between the vaginal orifice and the anus in a female and between the scrotum and the anus in a male. Risk factor, anything that increases an individual's chance of developing a disease. Some risk factors, for example, smoking, can be avoided, but others cannot, for example, age and family history. Okay, so you will need to highlight amenorrhea, dysmenorrhea, and menorrhagia. This chapter does have some doozies on the words. So the cool thing about gynecologic and obstetrics is that you don't have to be working in an OBGYN field to be doing these things. You could be working for your family doctor. A lot, especially our female family doctors, they do perform gynecologic and obstetrics visits for their patients if they're in between on trying to find an OBGYN. So this is kind of good to know no matter where you decide to go in the field. All right. Let's see. Lily, go ahead and read the first paragraph under breast examination.
The provider usually begins the gynecologic examination with the breast examination. The medical assistant is responsible for assisting the patient into the supine position. The provider inspects the breast and nipples for swelling, dimples, puckering, and changing skin texture. The nipples are checked for abnormalities such as bleeding and discharge. The breast and axillary lymph nodes are palpated for lumps, hard knots, and thickening.
All right, very good. So you're going to want to highlight the first two sentences. Jasmine, it says supine position. What does that mean?
Can anybody answer?
Yeah, hold on a second. Let me see. Jasmine, can you hear me?
Laying. Yes, I can hear you.
Okay, all right. Go ahead and tell me what it means to be in a supine position.
It's like whenever they lay down on their back. Like,
That's right. Yep. Supine spine. Very good. Okay. So how many of you ladies have been taught or have read about performing self breast examinations?
Yeah.
I have to do them now because I have a lump on my it's on my right breast, so I have to do it probably like every 3 to 6 months.
Yes. Yep, very good. So yeah, so a lot of times, especially once you start having your menstrual cycles, it's important to do a routine breast self-examination at least once every month, or otherwise, depending on what your doctor has advised for you. But it is really good, and the chapter will cover this. It is really good to, if you do not know how to do it, make sure you do, because it becomes a little bit more in ease when we're explaining to our patients the process and why we do it. Um, very good. Okay, now it says axillary lymph nodes. Alicia, what does that mean?
I don't know.
All right, anybody else want to try?
It said pale, there are pale lumps, yeah, and hard knots.
Yes. So axillary lymph node. So the axillary is, what we probably refer to as the armpit, right? In the arm. So everybody has lymph nodes um, throughout their body. When certain lymph nodes become larger, where we can actually feel the lymph node, then it could be a sign that something else is going on. So that's why not only does your provider feel of the breast and the nipple area, but they also are going to feel underneath your arm and in your armpit to make sure that they don't feel any abnormalities with the lymph nodes that are in that axillary area. All right, very good. Let's see. Nancy, go ahead and read the next paragraph, please.
The patient should know how to, we're on the patient, no, right?
Yes.
Okay, the patient should know how to examine her breast at home for the presence of lumps and other changes with a breast self-examination. Most breast cancers are first discovered by women themselves. The American College of Obstetricians and Gynecologists recommend that women 20 years of age and older examine their breasts once every month. The American Cancer Society states that a BSE is a option for women starting in their 20s. The medical assistant may be responsible for instructing the patient in this procedure at the medical office. Procedure 8.1. If a lump or other changes is discovered, the woman should be scheduled an appointment with her provider as soon as possible. Most breast lumps are not cancerous, but the provider must make that diagnosis.
All right, very good. So I want you to highlight the words breast self-examination, BSE, and also highlight that the American College of Obstetricians and Gynecologists recommends that women 20 years of age and older examine their breast once every month. The American Cancer Society, ACS, publishes breast cancer screening recommendations for women at average risk for breast cancer. A woman at average risk does not have a personal history of breast cancer, a family history of breast cancer, a genetic mutation known to increase risk of breast cancer, such as BRCA, and has not had chest radiation therapy before the age of 30. The ACS breast cancer screening recommendations are outlined in box 8.1. All right, so let's quickly read box 8.1. Women between 40 and 44 should have the choice to start annual breast cancer screening with mammograms if they wish to do so. Women 45 to 54 should get mammograms every year. Women 55 and older should switch to a mammogram every other year, or they can choose to continue yearly mammograms. Screening should continue as long as a woman is in good health and is expected to live 10 more years or longer. All women should be familiar on how their breasts normally look and feel and report any changes to a health care provider right away. All right, any questions on any of this so far? Okay, so let's go ahead on page 238. Let's go ahead and start with our first case study number 1. Carol Rooster, 47 years old, has come to the office for a gynecologic examination. She has not had a gynecologic examination in 10 years. Miss Rooster picked up a BSE brochure at a local health fair and performed a breast self-examination at home. She is now concerned because she found some unusual findings. Her right breast is slightly larger than her left. Her left nipple is pulled in, and she found some freckles on her right breast. Miss Rooster explains that she has not had a gynecologic examination in such a long time because her periods have always been normal and regular. She also says that the physician will probably want her to have a mammogram, and she has heard that it hurts to have one. Miss Rooster is afraid that the physician will be annoyed with her for not having a gynecologic examination sooner. Okay, so first one is, what would you do?
Don't judge her.
That's right. Very good. What else?
Inform her that yes, a mammogram does hurt, but there is another option. Because when I had to go get a mammogram, they gave me an option to do a mammogram or ultrasound, so I chose an ultrasound.
Okay. So that's actually a good point for bringing that up. So for some women, that is an option. For example, I have to get a mammogram once every year. I'm only 38 years old, but they do an ultrasound first. And then if they feel that they need to do a mammogram, then they'll proceed to the mammogram. So for some patients, that is an option, but you would definitely want to make sure that you speak with your provider first, or advise the patient that, to talk to the physician to see what options they may have available. So that is a very good point. Good job. All right, what else? Okay, well, let me ask this since we're all still a little quiet this morning. Um, she's not had a gynecologic examination in years, but her periods are normal. What does that mean? Does that mean anything?
We'd still have to her to
Yeah,
make sure that she sees her OB.
that
Just
very
because her
good.
cycles are normal does not mean that there couldn't be something
That's
wrong.
right. That's right. Very good. Yeah. So we want to always advise our patients that just because your periods are normal, it's not saying that something is wrong, but you may necessarily have normal periods and something could be going on that, you're not noticing. All right. Very
We
good.
could tell her that breast changes are normal, throughout aging, but taking a look and letting her, know.
That's right. So there again, yes, you're speaking to the patient. You're letting them know that, okay, not many women, I think, unless you've had them surgically done, they have perfect breast. I've never seen it. I don't even have perfect breast. So it's normal to notice them changing. Sometimes if let's say you write with your left hand, you may notice that your left breast is bigger than your right, or vice versa. If you drink a lot of caffeine, you may notice a little different feeling in your breast as well. So it's not everybody has perfect. It is normal for some changes, but you also want to recommend that to your patient that even if you think it's normal or not normal, go ahead and ask, right? We'd rather let our patients know, assure them that, everything's okay than for them to assume. So that you always make sure you give them that feedback. All right, good. All right, anybody want to add anything else?
And she says is afraid that the physician will be annoyed with her. I guess reassure her that, the physician's not gonna judge her or, make her feel like she's done something wrong or anything like that.
That's right. That's right. We're going to let her know that we just really appreciate that she's here today, and we're going to make sure that, she gets the best care possible. So that's right. Very good. All right. Good, 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 good. Okay, so now we're on to pelvic examination. Let's see. Sabrina, go ahead and read the first paragraph, please.
The purpose of the pelvic examination is to assess the size, shape, and location of the reproductive organs and to detect the presence of a disease. The pelvic examination consists of the following components: inspection of the external genitalia, vagina, and cervix, collection of specimen for a pap test, bimanual pelvic examination, and rectal vaginal examination.
Very good. Okay, I want you to highlight where it says pelvic examination and go and highlight each of those bullet points. All right, Talia, go ahead and read the next paragraph.
For the pelvic examination, the patient is positioned in the lithium position. The patient lies on a table on her back with her feet in the stirrups and her buttocks at the bottom edge of the table. The stirrups should be level with the examination table and pulled out approximately 1 foot from the edge of the table. The patient's knees should be bent and relaxed, and her thighs should be rotated outward as far as comfortable. This position helps relax the valvula and the perineum and facilitates insertion of the vaginal speculum. The patient should be properly draped to reduce the exposure and to provide warmth. The lithium position is difficult to maintain, and the patient should not be placed in this position until the provider is ready to begin the examination.
Very good. Okay, so I want you to highlight the first sentence where it says, for the pelvic examination, the patient is positioned in the lithotomy position. All right, Alicia, go ahead and read the next paragraph.
The medical assistant can help the patient relax during the examination by telling her to breathe deeply, slowly, and evenly through the mouth. If the patient is relaxed, it is easier for the provider to insert the vaginal speculum and to perform the bimanual pelvic examination. It also is more comfortable for the patient. It is recommended that the medical assistant remain in the room during the pelvic examination to provide legal protection for the provider, to reassure the patient, and to assist the provider. Procedure 8.2 outlines the medical assistant's role in assisting the provider with gynecologic examination.
All right, very good. All right, you're going to want to highlight the first two sentences on that paragraph. All right, so if your provider is a female, do you still want to make sure that you're in the room?
Yes, ma'am.
Yes. You never leave your provider's side unless otherwise told. Never. I don't care what, female or male. You never leave their side. All right, very good. Anna, go ahead and read the first paragraph on the inspection of external genitalia, vagina, and cervix.
The provider begins the pelvic examination with inspection of the internal genitalia, the vulva.
Vulva.
Vulva is expected of swelling, ulceration, and redness.
Very good. Jasmine, go ahead and read the next paragraph, please.
Next, the provider inserts a vaginal speculum into the vagina. Specula are available in two forms, plastic and metal. Plastic specula are used most commonly in the medical office. They are disposable and are designed to be used only once. Metal specula are reusable and must be sanitized and sterilized after each use. Vaginal specula come in three sizes, small, medium, and large. The provider determines the size required based on the physical and sexual maturity of the patient. The function of the speculum is to hold the walls of the vagina apart to allow visual inspection of the vagina and cervix.
Very good. Thank you, sweet little baby. Okay, I want you to highlight the last sentence. Right, Lily, go ahead and read the next paragraph.
On inspection,
Yes.
where it says next, or is that not where we're at?
Go to the next paragraph. It'd be the third one.
A metal vaginal speculum is cold and should be warmed use before use by placing it on the heating pad or by storing it in a warming drawer. A warm speculum is more comfortable for the patient. It is important not to overheat the speculum. However, one that is too hot is just as uncomfortable as one that is too cold. A disposable plastic speculum does not hold the cold and does not need to be warmed.
Very good. So for this purpose, that's why your provider, it's more common to see the plastic speculums than the metal, because generally you won't need to have to warm them up or anything. All right. Nancy, read that next paragraph.
Provider inspects the vagina and the cervix for color, lacerations, ulcerations, redness, nodules,
Nodules.
and discharge. If an abnormal discharge is present, the provider obtains a specimen for laboratory evaluation. Examples of pathologic conditions that produce a discharge include vaginal infections and such as trichomoniasis,
Trichomonious.
candidiasis,
Mm-hmm.
chlamydia, and gonorrhea, which are discussed in detail later.
All right, very good. So that's another thing this chapter is going to go over. It's going to be some of our sexually transmitted diseases. All right, very good. So a pap test. A pap test is usually part of the pelvic examination. It is a simple and painless cytology evaluation named after its developer, Dr. George Papanicolaou. Yeah. It was used for the early detection of cervical cancer. Highlight that sentence. Almost all cancers of the cervix can be cured if detected early enough. The Pap test is also used to detect abnormal, atypical cells of the cervix that might develop into cancer if not treated. In some cases, the Pap test can detect cancer of the endometrium. However, it is less reliable in doing so. Almost all cervical cancers are caused by the human papillomavirus, HPV. HPV is a common virus that can be transmitted from one individual to another during sexual intercourse. Go ahead and highlight that first sentence where it says almost all cervical cancers are caused by the HPV. There are many strands of HPV, but most of these strands do not pose a health risk. Certain strands of HPV are called high-risk strands because they can cause changes to a woman's cervix that can lead to cervical cancer over time. The ACS publishes recommendations for cervical cancer screening, which are outlined in box 8.2. Although HPV infection has the strongest link to development of cervical cancer, there are other factors that place a woman at higher risk for cervical cancer. These include cigarette smoking, weakened immune system due to HIV virus infection, organ transplantation, chemotherapy, or long-term steroid use, having given birth to 3 or more children, use of oral contraceptives for more than 5 years, and DES exposure before birth. Sabrina, go ahead and read patient instructions.
The patient should be instructed to schedule her Pap test 10 to 20 days after the first day of her last menstrual period. This is because it is recommended that the Pap test not be collected during the patient's menstrual period. The patient should be told not to douche or insert tampons, vaginal medications, lubricants, or contraceptives, spermicides into the vagina for 2 days before having a Pap test. Douching or tampon insertion reduce the number of cells available for analysis, and vaginal medications and spermicides change the pH of the vagina, making a specimen non-representative or invalid. The patient also should be told to abstain from sexual intercourse for 2 days before the Pap test. Recent sexual intercourse can produce inflammatory changes that can interfere with visualization of abnormal cells that may be present.
Very good. Okay, so you're going to highlight the first 3 sentences, and then also continue to highlight where it says douching and tampon insertion reduce the number of cells available for analysis, and vaginal medication and spermicides change the pH of the vagina. All right, Talia, go ahead and read specimen collection.
The outermost layer of the cervix consists of a thin, flat layer of cells, approximately 10 layer thick, known as the squamous epithelial cell. With the speculum in place, the provider collects a sample of these cells for evaluation by the laborer. A cramping of epithelial cells is taken from the ectopical cervix and the endocervix. A scraping of these cells also can be collected from the vagina. However, this is not usually done unless the providers have observed a lesion on the vaginal wall or the maturation index is to be determined. The technique used by the provider to collect the epithelial cell used a spatula and brush is described next, and the technique used to collect the cells using a broom is described later in this section.
All right, very good. All right, Alicia, go ahead and read vaginal specimen.
If a vaginal specimen is needed, it is collected first. Before the cervix and cervical specimens are obtained, the rounded end of the plastic spatula is used to collect the specimen. If a routine vaginal specimen is obtained, it is collected from the vaginal pool in the posterior fornix of the vagina, which is located just below the cervix, figure 8.3a. If the provider is collecting a specimen from a lesion on the vaginal wall, a scraping of cells is taken from the area of the lesion. To obtain a specimen for determination of the maturation index discussed later, the provider obtains the vaginal wall from the upper 1/3 of the lateral vaginal wall.
All right, very good. Anna, can you go ahead and read cervical specimen?
Cervical specimen. The provider obtains the cervical specimen by placing this S-shaped end on the plastic spectacle just inside the cervical canal at the external OS. Rotating the blade 360 degrees over the surface of the exocervix at the
Squama columnar.
okay junction where cervical cancer is most often found, figure 8.3b. The exocervix is the part of the cervix that projects into the vagina and is lined with a stratified, how do you say that word again? Squamous
Epithelium. Yep.
epithelium.
Yep. I told you guys this chapter's got some doozies. All right, very good. So I want you to highlight that first sentence just where it says the provider obtains a cervical specimen by placing the S-shaped end of the plastic spatula. All right, Jasmine, go ahead and read endocervical specimen.
The provider collects the specimen from the endocervix. The endocervix consists of the mucous membrane lining the endocervical canal. This is accomplished by inserting an endocervical brush into the endocervical canal and rotating the brush. The endocervical brush is made up of soft bristles designed to be inserted into the canal without causing damage to it.
All right, very good. So now I want you guys to look at figure 8.3 on page 241. So A, B, C. So A is the posterior fornix. That's the rounded end of the spatula that's used to obtain the vaginal specimen. B is the S-shaped end of the spatula. And C, an endocervical brush. So those are the three type of brushes that you will use when performing specimens for a pap smear. All right. Two methods are used to prepare a specimen for a pap test. They include the more conventional direct smear, pap smear method, and a liquid-based preparation method. Let's see here. Lily, can you go ahead and read the first paragraph for the direct smear?
With the direct smear method, a thin smear of each specimen is spread on a glass slide that has a frosted edge. The medical assistant must label each slide on its frosted edge with a lead pencil according to the source of the specimen as follows: B, vaginal; C, cervical; or E, endocervical. Slides on which all three specimens can be placed also are available. These slides are divided into thirds and are pre-labeled with B, C, and E.
All right, very good. I want you to highlight that the medical assistant must label each slide on its frosted edge with a lead pencil according to the source of the specimen as follows: B, vaginal; C, cervical; E, endocervical. Vaginal. All right, any questions about that so far? Okay, as the medical assistant, when do you think we will label the slides? Before or after the specimens?
Before.
That's right, before. Very good. All right. Let's see. Talia, go ahead and read the next paragraph, please.
The smears must be fixed immediately by flooding these slides with 95% ethyl alcohol or by lightly spraying these slides with a commercial cytology spray fixative. The slides must be fixed before they dry to avoid interactive results. The purpose of the fixation are to maintain the normal appearance of these cells, to protect these slides from contamination in the air, such as dust and bacteria, and to attack the smears firmly to the slide. The cytology fixation must be allowed to dry thoroughly. The slides are then ready for transferred to a laboratory for evaluation. To protect the slides during transport, they must be placed in a slide container designed especially for this purpose.
All right, very good. So we're going to take a quick 2-minute little break here, and then we'll come back and we'll finish this up. All right, so let's see. Alicia, go ahead and read liquid-based preparation.
The most commonly used method to prepare the pap specimen for evaluation is the liquid-based preparation method. Brand names include ThinPrep and SurePath. Use of the liquid-based method improves the quality of the specimen, resulting in fewer slides that are unsatisfactory for evaluation. A better quality specimen also reduces the occurrence of a false negative test result.
Very good. So I want you to highlight the words ThinPrep and SurePath, but I will tell you ThinPrep is a more commonly used. All right, Anna, go ahead and read the next paragraph, please.
The specimen for a liquid-based preparation could be obtained by using the specimen collection technique described earlier. A plastic spatula, a shaped end, is used to collect the
Ectocervical.
ectocervical specimen, and the ectocervical brush is used to collect the ectocervical specimen. In a vaginal specimen is needed. It is collected first using the rounded end of the scapula as previously described.
Very good. All right. The Pap specimen also can be collected using a broom, a collection device made of flexible plastic. The provider inserts the central bristles of the broom into the endocervical canal deep enough to allow the shorter bristles to contact the outside of the cervix fully. The broom is gently pushed and rotated in a clockwise direction. In this way, specimens from the ectocervix and the endocervix can be collected at the same time. When the Pap specimen has been collected, the medical assistant is responsible for performing one of the following steps depending on the brand of liquid-based preparation being used. Number 1, rinse the collection device in the vial of the liquid preservative and discard the collection device, performed with a thin prep. Number 2, remove the tip of the collection device and deposit in the vial of the preservative. Discard the handle, performed with SurePath. The preservative maintains the specimen and prevents it from drying out during transport to the laboratory. After it is received by the laboratory, the vial is placed in the automated slide preparation processor. The automated processor performs several important functions. First, it separates the cells from debris present in the specimen, and then it disperses a representative cell sample onto a slide in a thin, uniform layer. The slide is next immersed in a fixative to maintain the normal appearance of the cells. I want y'all to highlight where it says, first it separates the cells from debris present in the specimen, and then it disperses a representative cell sample onto a slide in a thin, uniform layer. Cytology request. A cytology request must accompany all Pap specimens. Figure 8.5 is an example of a cytology request form. The medical assistant is responsible for completing the request, which includes the following categories. General information. General information includes the provider's name, address, and phone number, and the patient's name, address, identification number, date of birth, and date of last menstrual period, LMP. Insurance information also is required in this section for third-party billing. Date and time of collection. Date and time of collection indicate to the laboratory the number of days that have passed since the collection, providing the laboratory with information regarding the freshness of the specimen. The collection method. Under the collection method category, the medical assistant must indicate whether the specimen is a liquid-based preparation or a direct smear, Pap smear. Source of the specimen. The purpose of this category is to identify the origin of the specimen because it is important for the laboratory, it is impossible for the laboratory to obtain this information by looking at the specimen. The medical assistant checks one or more of the following boxes on the form: cervical, endocervical, or vaginal. Collection technique. The collection device or devices used to obtain the specimen must be indicated. The medical assistant checks one or more of the following boxes on the form: spatula, brush, or broom. Patient history. Information on the present and past health status of the patient is specified under the patient history category. The medical assistant must check the following boxes that apply to the patient: pregnant, lactating, oral contraceptives, postmenopausal, hormone replacement therapy, postmenopausal bleeding, postpartum intrauterine device, IUD, post-coital bleeding, DES exposure, and previous abnormal smear. This information assists the laboratory in evaluating the specimen. Previous treatment. Any previous treatment for a precancerous or cancerous condition of the cervix is indicated under this category. The medical assistant checks the appropriate box on the form if any of the following procedures have been performed on the patient: colposcopy and biopsy, cryosurgery, loop electrocautery excision procedure, LEEP, laser evaporation, condensation, hysterectomy, radiation, and chemotherapy. Any questions on that so far?
No, ma'am.
All right. Evaluation of the Pap specimen. Before a Pap slide can be evaluated, it must be stained by a laboratory technician. Staining is performed on the slides prepared by the direct smear method and the liquid-based method. The purpose of staining is to allow better viewing of the morphology on the epithelial cells. The slide is studied under a microscope for evidence of abnormalities by a specially trained technician known as a cytotechnologist. When an abnormality is detected, it is reviewed by a cytopathologist, a provider specializing in pathology, who makes a final evaluation. The findings are documented on a cytology report and returned to the medical office. A more recent development in the evaluation of Pap slides is the use of automated cytology computer imaging devices. An abnormal slide may contain only few abnormal cells among thousands of normal cells. Because of these abnormal cells may be missing during the evaluation by the cytotechnologist. A cytology computer imaging device is able to examine every cell on the slide and select and display cells that appear most abnormal. The cytotechnologist can evaluate these cells further under a microscope. In this way, the cytotechnologist is able to focus his or her expertise and decision making on pre-selected areas of the slide. Okay, so really quickly before we go on to page 244, I want you guys to look at figure 8.5. This is a cytology request form. So just like if we were sending our patient off to get their lab drawn, we would fill out a lab requisition. For cytology, you would fill out a requisition form as well. They're just two different types of forms. This is something in most cases as a medical assistant, you will fill out most of this prior to the doctor performing his examination. All right, any questions on anything so far?
No, ma'am.
All right, so maturation index. The maturation index must be performed on a sampling of cells taken from the upper third of the lateral vaginal wall. The maturation index refers to the percentage of parabasal, intermediate, and superficial cells present in the specimen. The maturation index provides the provider with an endocrine evaluation of the patient. Highlight that part. Which can assist in evaluating, I can't talk today. Evaluating the cause of,
What are we supposed to?
Highlight where it says the maturation index provides the provider with an endocrine evaluation of the patient.
Out of curiosity, am I the only one that's having problems because it keeps like loading, or is it?
I've not had any problems this morning on my end, but I do think the internet is having issues itself.
Okay.
If you keep noticing that, Nancy, I would go out of it. Let me make sure I still have the meeting unlocked. Yeah. Go out of it and come back in and see if that helps. But if not, like I said, I'm going to upload this one today too.
Okay.
All right, which can assist in evaluating the cause of infertility, menopausal or postmenopausal bleeding, or amenorrhea, and can help assess the results of treatment with hormones. If the provider orders a maturation index along with the Pap test, the medical assistant must indicate this on a cytology request by checking the box labeled maturation index. Numerous factors affect the results for the maturation index. It is important to indicate on the cytology request the presence of abnormal bleeding, hormone treatment, or treatment with digitalis, corticosteroids, or thyroid medication. Goodness, this chapter's got some big words. You don't say it very often, but man, it's a doozy every time you have to say it. Okay, cytology report. The TBS, the Bethesda system, is a standard for reporting the results on a Pap test on a cytology report. The National Cancer Institute of Bethesda, Maryland, developed a system. Highlight where it says it provides a detailed cytologic description rather than a numerical result. As with the previous class 1 through 5 system. For this reason, TBS is a more effective means of communicating the results of the Pap test to the provider. The TPS separates the cytology report into the following categories. All right, let's see. Jasmine, can you go ahead and read number 1?
Specimen type. This category identifies whether the specimen is a conventional cell sample, Pap smear, or liquid-based cell sample.
All right, very good. Lily, go ahead and read number 2, just that first specimen adequacy.
Specimen adequacy. This category refers to the quality of the specimen collected by the provider. The specimen is described using one of the following classifications.
All right, very good. Satisfactory for evaluation. This indicates that the specimen was a sufficient sampling and quality for the comprehensive assessment of the cells. Unsatisfactory for evaluation. This indicates that the overall sampling or quality of the specimen was inadequate. A reason is given for the inability to evaluate the Pap slide, such as too few cells were collected or the presence of blood or inflammation is obscuring the cells. Nancy, can you go ahead read number 3 and just that first bullet point?
General categorization. This category provides the medical office with a quick review of the report. The following classifications are used to categorize the specimen. Negative for intraepithelial lesions or malignancy. This indicates that the epithelial cells were normal and that there were no precancerous or cancerous findings. The classification also is assigned to the specimen that exhibits certain benign, non-cancerous changes. Benign changes can be caused by vaginal infections such as bacterial vaginosis, chlamydia, trichomoniasis, these words, candidiasis, and herpes. Benign changes also can be caused by inflammation resulting from normal cells repair process, radiation, and chemotherapy. Any benign findings of importance. Example, vaginal infections are described in detail in the interpretation result section of the cytology report.
Very good. All right. Yep. Some doozy words in this one. Okay. So the epithelial cell abnormality. This classification indicates abnormal cell changes. The abnormality is described in detail in the interpretation results section of the report. This classification is used to indicate that no abnormality was found in the cells, but the findings indicate some increased risk. The presence of normal appearing endometrial cells in the postmenopausal women may indicate an abnormality in the endometrium. These findings are described in detail in the interpretation results section of the report. Sabrina, go ahead and read interpretation results.
This part of the report provides the provider with a detailed description of findings. This includes any significant benign changes and any abnormal changes in the epithelial cells. Table 8.1 lists and describes the findings most frequently reported.
Very good. Talia, go ahead and read number 5.
Automated review. This category indicates whether the spectrum was evaluated using an automated computer imagining device. The name of the device and results are specified in this section.
All right. And Alicia, go ahead and read number 6.
This category is used if an additional test method is used to evaluate the specimen. If abnormal cells are detected on the Pap site, a human papillomavirus HPV test may be performed. The name of this test method and results would be reported under this category.
All right, very good.
Auxiliary testing.
Yes. Yep. All right, I want you guys to look at the table 8.1. So this is pretty common on how the Pap test results may be viewed on your report. So for negative or intraepithelial lesion or malignancy, that means it was normal, no findings of anything. Atypical squamous cells of undetermined significance. Cells are only slightly abnormal. Nature and cause of abnormality cannot be determined. These slightly altered cells can usually return to normal on their own, resulting in negative results on a subsequent Pap test, which means if you receive this result, your doctor may want your patient to come in for a repeat in maybe 3 months. Atypical squamous cells of higher risk. Minor abnormal changes in cells with unknown causes, but a risk of progressing to high-grade lesion. Further testing is required to determine whether this is a minor condition or one that may progress to HSIL. Low-grade squamous intraepithelial lesion. Abnormal cells that show definite minor changes but are unlikely to progress to cancer. General term for this is mild dysplasia. LSIL may be caused by the HPV infection, but a type that is not likely to lead to cervical cancer. High-grade squamous intraepithelial lesion. Abnormal cell changes that have a higher likelihood of progressing to cancer. Although not cancerous yet, abnormal cells may become cancerous if treatment is not obtained. General term for this is moderate to severe dysplasia. HSIL is often caused by the HPV infection of a type associated with cervical cancer. Carcinoma usually means patient has cervical cancer. Most women with cervical cancer also test positive for HPV infection. All right, any questions? All right, bimanual pelvic examination. After obtaining the smear for the Pap test, the provider withdraws the speculum and performs a bimanual pelvic examination. The provider inserts the index and the middle fingers of a lubricated gloved hand into the vagina. The fingers of the other hand are placed on the woman's lower abdomen. Between the two hands, the provider can palpate the size, shape, and position of the uterus and ovaries and can detect tenderness or lumps. Highlight that last sentence. All right. Anna, can you go ahead and read rectal vaginal examination?
Yes. The last part of the pelvic examination is a rectal vaginal examination. The provider inserts one glove finger into the vaginal and another glove finger. I'm sorry, he's mad.
That's okay. You wanna calm him
Yes.
down? Okay.
Yes, please.
That's all right. Not a problem. Jasmine, can you go ahead and pick up, please?
Where did she leave off?
If you want to start where it says just the provider inserts one gloved finger.
The provider inserts one gloved finger into the vagina and another gloved finger onto the into the rectum to obtain information about the tone and alignment of the pelvic organs and the adnexal region, which is the ovaries, fallopian tubes, and ligaments of the uterus. The presence of hemorrhoids, fistulas, and fissures also can be noted. During this examination, the provider may want to obtain some fecal material from the rectum to test for occult blood in the stool, which is hemoccult. This is typically performed on women beginning at 40 years of age. The medical assistant is responsible for assisting with the collection and testing the specimen for occult blood. This procedure, fecal occult blood testing, is presented in detail in Chapter 13.
Yes. All right, very good. So I want you guys to highlight the second sentence and also highlight that this is typically performed on women beginning at 40 years of age. Okay, I want you guys to turn to page 249. On number 7, procedural step, I want you to highlight where it says prepare the patient for the examination as follows. And I want you to highlight A and B. When I get done here, we'll be going to the school. Yeah, go ahead and get dressed and get you something to snack on. Okay. All right, sorry about that, guys. Okay, now then I want you to go to page 250. And I want you to highlight the number 14 procedural step. And then we're going to turn on to page 252. Vaginal infections. The vagina provides a warm, moist environment which tends to encourage the growth of various organisms that can result in a vaginal infection or vaginitis. If an unusual vaginal discharge is present, suggesting a vaginal infection, a specimen is obtained to identify the invading organisms. A specimen of the vaginal discharge is collected at the medical office and is evaluated there or placed in an appropriate specimen container that is picked up by a laboratory carrier and transported to an outside medical laboratory for evaluation. The medical assistant is responsible for assembling the appropriate supplies for the collection and evaluation of the suspected invading organism. The medical assistant must label all specimens with the patient's name and date of birth, the date, and the source of the specimen. If the specimen is to be transported to an outside medical laboratory for evaluation, a laboratory request form must be completed. The request form indicates the source of the specimen, the provider's clinical diagnosis, and the laboratory test requested. The provider's clinical assessment of the patient's signs and symptoms, along with the results of the laboratory evaluation of the specimen, are used to diagnose the presence of a vaginal infection. Medical assistants should protect themselves from infection with the pathogen while assisting with the collection and evaluation of the specimen by practicing good techniques of medical asepsis. Methods used to identify the invading organism and supplies required for the collection and evaluation of organisms that can cause common vaginal infections are presented next. Okay. Lily, why don't you go ahead and read trichomonias?
Trichomonias vaginalis, the causative agent of trichomonias, is a pearl-shaped protozoan with 4 flagella that allow for the motility of the organism. Trichomonas is usually but not always spread through sexual intercourse. Symptoms of this infection include a profuse, frothy vaginal discharge that is usually yellowish green and has an unpleasant odor, itching and irritation of the vulva and vagina, dyspareunia and dysuria. The cervix may exhibit small red spots, a condition known as strawberry cervix.
All right, very good. I want you to highlight the words protozoan and motility. And I want you to highlight the symptoms. All right, Nancy, can you go and read the next paragraph, please?
Trichomonas
Mm-hmm.
may be identified at the medical office by a wet preparation, which involves placing a small amount of the discharge on a microscope slide using a sterile swab, adding a drop of isotonic saline to it, and placing a cover slip over the mixture to protect it. Figure 8.9. The slide is examined under the microscope and observed for the presence of the lashing movements of a flagella,
Mm-hmm.
and the motility of the organism. If the provider prefers to have an outside laboratory evaluate the specimen, it must be placed in the appropriate specimen container and transported to the laboratory for evaluation. Trichomonas
You can go ahead. You can finish it.
Trichomonias is treated with the oral administration of the metronidazole. The woman and her sexual partner must be treated at the same time to prevent reinfection because her partner may harbor the organism without displaying noticeable symptoms.
All right, very good. I want you to highlight where it says, which involves placing a small amount of the discharge on a microscope slide using a sterile swab, adding a drop of isotonic saline to it, and placing a cover slip over the mixture to protect it. And then highlight where it says trichomonias is treated with the oral administration of metronidazole or Flagyl. All right, Sabrina, go ahead and read the first paragraph under candidiasis.
Candida albicans is a yeast-like fungus normally found in the intestinal tract and is frequent contaminant of the vagina. However, it usually does not produce symptoms indicating a vaginal infection. Conditions such as pregnancy, diabetes, mellitus, and prolonged antibiotic therapy produce changes in the vagina that may precipitate a candidal infection of the vagina, commonly referred to a yeast infection. Symptoms of candidiasis include white patches of the mucous membrane of the vagina, a thick, odorless cottage cheese-like discharge, vulval irritation, and dysuria. The discharge is extremely irritating and usually results in burning and intense itching.
All right, very good. All right, I want you to highlight where it says the Candida albicans is a yeast-like fungus normally found in the intestinal tract. Also highlight where it says prolonged antibiotic therapy produces changes in the vagina that may precipitate a candidial infection of the vagina. And highlight a thick, odorless cottage cheese-like discharge. All right, Talia, go ahead and read the next paragraph.
Candida may be identified microscopically in the medical office by placing a specimen of the vaginal discharge on a slide using a sterile swab and adding a drop of a 10% solution of potassium hydroxide, KOH. KOH divides the cellular debris present in the smear and allows better visualization of yeast buds, spores, or hyphae, fungi, filaments. Indicates the presence of C. Billikens, figure point 8.10. If the provider prefers to have an outside laboratory evaluation, the specimen, it must be placed in the appropriate specimen container and transported to the laboratory.
All right, very good. I want you to highlight where it says the KOH dissolves cellular debris present in the smear and allows better visualization of the yeast buds, spores, and the hyphae. All right, the candidiasis is treated with the application of vaginal ointments or suppositories such as miconazole, Monistat, clotrimazole, Lotrimin, and nystatin, mycostatin, or the oral administration of fluconazole, diflucan, highlight that part. Candidiasis has a tendency to recur. The patient should be instructed to contact the medical office if the symptoms of the yeast infection reappear. All right, now let's go on to chlamydia. Alicia, go ahead and read first paragraph, please.
Chlamydia is caused by the bacterium Chlamydia trachomatis, whatever.
Tomatus.
It
Yep.
is it is a gram-negative intracellular bacterium that grows and multiplies in the cytoplasm of the host cell. Chlamydia is most frequently reported and fastest spreading sexually transmitted infection in the United States, particularly among adolescent girls and young women. Because of this, the CDC recommends annual routine screening for chlamydia of all sexual active females 25 years of age or younger.
Very good. All right, so you're going to highlight the first two sentences. Anna, go ahead and read the next paragraph.
Most women with chlamydia do not. Most women with chlamydia have no symptoms and are not aware of having the condition. Because of this, many women do not seek medical care until serious complications have occurred. After infection, chlamydia first attack the cervix, resulting in cervicitis.
Mm-hmm.
If symptoms do occur, they may include one or more of the following: diarrhea, itching, and irritation of the genital area, and a yellowish odorless vaginal discharge. These symptoms usually appear 1 to 3 weeks after the patient has been infected.
All right, very good. So you're going to highlight if symptoms do occur, they may include one or more of the following: dysuria, itching and irritation of the genital area, and a yellowish, odorless vaginal discharge. All right, Jasmine.
Question.
Go ahead.
So does cervicitis, does that mean like inflammation of the cervix?
That's right.
Okay.
All right, and how did you guess that, Nancy?
Itis. Itis means inflammation.
Very good. So proud of you. Good job. Very, very good. All right, Jasmine, go ahead and read the next paragraph.
If not treated, chlamydia can spread further into the female reproductive tract and cause pelvic inflammatory disease, PID. The symptoms of PID include lower abdominal pain, fever, nausea, and vomiting. Dyspareunia. How do you say that?
Dyspareunia.
Dyspareunia, vaginal discharge, and bleeding between periods. Complications of PID are serious and include chronic pelvic pain, scarring of the fallopian tubes, ectopic pregnancy, and infertility.
Very good. All right, you guys are going to want to highlight that first sentence. Lily, go and read the next paragraph.
Symptoms of chlamydia infection in men include mild dysuria and thin watery discharge from the penis. Men are more likely to have symptoms than women. However, the symptoms may appear only early in the day and be so mild that they are ignored. If the infection is not treated, it can cause epididymitis, a painful condition of the testicles that could result in infertility.
All right, very good. You're going to highlight that last sentence. All right, Nancy, go and read the next one.
When diagnosed early, chlamydia can be treated successfully with antibiotics. The antibiotics most often used are azithromycin, Zithromax, and doxycycline. The patient partner also should be tested for chlamydia so that if treatment is needed, it can be administered as soon as possible.
All right.
Chlamydia is most
Go ahead.
Chlamydia is most frequently diagnosed using a nucleic acid amplification test, NAAT, or a nucleic acid hybridization test known as a DNA probe test. These tests are able to detect the presence of genes, DNA, of chlamydia bacteria. The provider collects a specimen using sterile swab. The specimen is collected from the endocervical canal of a female patient and from the urethra of a male patient. Male patients should be instructed not to void for 1 hour before the collection of specimen to prevent chlamydia organisms from being washed out of the After collection, the specimen is placed in a tube containing a transport medium to preserve the specimen until it reaches the laboratory. See the box of chlamydia and gonorrhea specimen collection for detailed instructions on how to assist with the collection of chlamydia specimen.
Very good. All right, gonorrhea. Sabrina, go ahead and read the first paragraph, please.
Gonorrhea is caused by the bacterium Neisseria gonorrhoeae, which is a gram-negative diplococcus. Gonorrhea is an infection of the genitourinary tract that is transmitted through sexual intercourse. Chlamydia often occurs in association with gonorrhea. Approximately 25% to 40% of patients infected with gonorrhea also have chlamydia. The CDC recommends annual routine screening for gonorrhea in all sexually active women at risk for infection. Women younger than 25 years of age are at high risk for gonorrhea infection. Other risk factors include a previous gonorrhea infection, the presence of other sexually transmitted infections, STIs, and new or multiple sex partners.
Very good. Okay, you're going to highlight where gonorrhea is an infection of the genital urinary tract that is transmitted through sexual intercourse. Highlight chlamydia often occurs in association with gonorrhea. Approximately 25 to 40% of patients infected with gonorrhea also have chlamydia. All right, Talia, go ahead and read the next paragraph.
Women who have contracted gonorrhea may have no symptoms or may exhibit dysuria and a yellow vaginal discharge. The symptoms of gonorrhea, if they occur, appears 2 to 10 days after the infection, may be so mild that they are ignored. As this disease progresses, it can spread farther into the reproductive tract, resulting in PID. As mentioned previously, PID can lead to serious complications such as infertility.
Yes, very good. All right, Alicia, go ahead and read the next paragraph.
Men who have contracted gonorrhea exhibit more symptoms than women, including dysuria and a whitish discharge from the penis, which may progress to a thick and creamy discharge. The burning and pain experienced during urination are often severe, which usually promotes an infected man to seek early treatment. If not treated, gonorrhea may cause epididymitis, which could lead to infertility.
Very good. Highlight that last sentence. All right, Anna, go ahead and read the next paragraph.
Gonorrhea can be treated effectively with antibiotics. In recent years, gonorrhea bacteria have become resistant to the antibiotics typically used to treat the disease. Because of this, newer types of antibiotics have been developed. One of the most effective antibiotics used to treat gonorrhea is surfetonide. How do you say that?
Ceftriaxone.
Which is administered in one dose by injection.
Very good.
The medical office most frequently use a DNA probe test or a nucleic acid amplification test, which is the NAT, to diagnose gonorrhea. These tests detect the persistence of the genes of the gonorrhea bacterium, and the procedure of obtaining a specimen of the DNA probe test is outlined in the box. Chlamydia and gonorrhea specimen collection.
Very good. Okay, so highlight the first sentence on that last paragraph. All right, any questions? All right, Jasmine, go ahead and start reading obstetrics and prenatal care.
Obstetrics is the branch of medicine that deals with the supervision of women's health during pregnancy, childbirth, and the puerperium. Prenatal refers to the care of a pregnant woman before delivery of the infant. Prenatal care consists of a series of scheduled medical office visits for promotion of the health of the mother and fetus through prevention of disease and early detection, diagnosis, and treatment of problems common to pregnancy. such as anemia, urinary tract infection, and preeclampsia. Early detection of medical problems helps prevent serious complications in the mother and the fetus.
Good. Okay, so I want you to highlight on page 254 where it says prenatal care consists of a series of scheduled medical office visits for promotion of the health of the mother and fetus through prevention of disease and early detection, diagnosis, and treatment of problems common to pregnancy, anemia, urinary tract infection, and preeclampsia, and also highlight early detection of medical problems. All right, obstetric terminology. The medical assistant should know the common terms related to obstetric as follows. Braxton Hicks contractions, intermediate and irregular painless uterine contractions that occur throughout pregnancy. They occur more frequently toward the end of pregnancy and are sometimes mistaken for true labor pains. Dilation, stretching of the external os of the cervix from an opening of a few millimeters to an opening large enough to allow the passage of an infant, approximately 10 centimeters. Effacement, thinning and shortening of the cervical canal from its normal length of 1 to 2 centimeters to a structure within paper-thin edges in which there is no canal at all. Effacement occurs late in pregnancy, during labor, or both. The purpose of effacement, along with dilation, is to permit the passage of the infant into the birth canal. Embryo. The child in utero from the time of conception through the first 8 weeks of development, for example, the first 2 months of development. Engagement. The entrance of the fetal head or the presenting part into the pelvic inlet. Fetus. The child in utero from the 3rd month of conception to birth. During the first 2 months of development, it is called an embryo. Fundus. The dome-shaped upper portion of the uterus between the fallopian tubes. Gestation, the period of intrauterine development from conception to birth, the period of pregnancy. The average pregnancy lasts about 280 days or 40 weeks from the date of conception to childbirth. Gestation age, the age of the fetus between conception and birth. Infant, a child from birth to 12 months. Multigravidia, a woman who has been pregnant more than once. Multipara, a woman who has completed 2 or more pregnancies to the age of viability, regardless of whether they ended in live infants or stillbirths. Nulliparia, a woman who has not carried a pregnancy to the point of fetal viability, 20 weeks of gestation. Position, the relation of the presenting part of the fetus to the maternal pelvis. Postpartum, occurring after childbirth. Preeclampsia, a major complication of pregnancy, the cause of which is unknown, characterized by increasing hypertension, allobuminuria, and edema. If the condition is neglected or is not treated properly, preeclampsia may develop into eclampsia, which can cause maternal convulsions and coma. Preeclampsia generally occurs between the 20th week of pregnancy and the end of the 1st week postpartum. Presentation, indication of the part of the fetus that is closest to the cervix and delivered first. A cephalic presentation in a delivery in which the fetal head is presenting against the cervix. A breech presentation is a delivery in which the buttocks or feet are presented instead of the head. Primigravidia, a woman who is pregnant for the first time. Primipara, a woman who has carried a pregnancy to fetal viability, 20 weeks of gestation, for the first time, regarding of whether the infant was stillborn or alive at birth. Pura perineum, the period of time, usually 4 to 6 weeks after delivery, in which the uterus and the body systems are returning to normal. Highlight that one. Quickening, the first movements of the fetus into the utero as felt by the mother, which usually occurs between 16 and 20 weeks of gestation and is felt consistently thereafter. Toxemia, a condition that occurs in pregnant women that includes preeclampsia and eclampsia. If preeclampsia goes undiagnosed or is not satisfactorily controlled, it could develop into eclampsia, which is characterized by convulsions and coma. Trimester. 3 months are 1/3 of the gestational period. The 9 months of pregnancy are divided into 3 trimesters, each consisting of 3 months. From conception to 3 months is the first trimester. From 4 to 6 months is the second trimester. And from 7 to 9 months is the third trimester. Prenatal visits. Medical office visits for prenatal and postpartum care of the pregnant woman can be grouped into 3 major categories as follows. Highlight number 1, 2, and 3. First prenatal visit, return prenatal visits, 6 weeks postpartum visit. All right, Lily, go ahead and read first prenatal visit, that first paragraph.
The first prenatal visit generally occurs after the woman has missed her second menstrual period. If problems exist, the woman is seen after missing her first menstrual period. Regardless of whether or not the patient is happy and excited about the pregnancy, the first visit is often a stressful experience for the patient. The medical assistant plays an important role in relaxing the patient and relieving her anxiety.
All right, very good. Nancy, can you go ahead and read the next paragraph? Jack.
The first prenatal visit requires more time than subsequent prenatal visit. Sufficient time should be scheduled to allow a complete and accurate initial assessment of the pregnant woman. The components of the first prenatal visit vary depending on the medical office, but generally include the following.
All right.
Completion.
Go. Jack, get down. Go. God. Sorry about that. Okay. Very good. Okay, go ahead and read and highlight each of those bullet points for me, Nancy.
Okay. Completion of prenatal record form. Initial prenatal examination consisting of a complete physical examination. Of particular importance are breast, abdominal, and pelvic examination. Pelvic measurement may be taken at the time or during a return prenatal visit, prenatal patient education, and laboratory.
All right, very good. Thank you.
Mm-hmm.
All right, Sabrina, go ahead and read prenatal record.
The prenatal record provides information regarding the past and present health of the patient and serves as a database and flow sheet for subsequent prenatal visits. The prenatal record is essential in helping identify high-risk patients. The medical assistant is usually responsible for collecting a portion of the information required for the prenatal record. Many types of prenatal record forms are available. The specific form used in the medical office is based on the provider's preference and the method used for conducting the prenatal examination.
All right, very good. You're going to want to highlight the first 2 sentences. All right, Talia, go ahead and read the next paragraph, please.
Okay, we're on prenatal record now. Hello?
What is it?
Is it the many types? I'm on 2-4.
On 258.
Yes, the many types.
No. The
Yes.
next one. I see what you're talking about. No, the next paragraph. I'm sorry.
Oh, okay. Okay. That's not paragraph. Okay. Obtaining the documentation information in the prenatal record from one visit to the next provides an opportunity for the medical assistant to develop a rapport with the patient. It's also an excellent time to relay information to her regarding various aspects of the prenatal and postnatal period, such as explanation of the changes occurring in her body, the signs and symptoms of labor, nutrition of the infant, breastfeeding and bottle feeding, and care of the newborn infant. The prenatal record form should be completed in a quiet setting that is free from distractions. This gives the patient the confidence to discuss areas of concerns openly, which helps ensure a complete and accurate prenatal history.
Awesome. Very good. All right, Alicia, go ahead and read the next paragraph, please.
During the first prenatal visit, the medical assistant should relay his or her name and position to the patient to help build a supportive relationship with her and to allow her to ask for the medical assistant by name when contacting the medical office. The prenatal record is similar to and contains much of the same information as the health history described in Chapter 1. Particular attention is given to the factors that may influence the course of pregnancy as described in the following paragraphs.
All right, very good. So figure 8.11 is a common prenatal health history, and it does look very similar to what a health history form may look for any other specialty field, but this one is specifically designed for prenatal. So that's a pretty common the way that looks. All right, very good. Anna, go ahead and read past medical history, just that paragraph.
The past medical history focus on conditions that could affect the health of the mother and the fetus, such as diabetes, hypertension, heart disease, autoimmune disorder, kidney disease, liver disease, variolations, or
Phlebitis.
phlebitis, alcohol and tobacco intake or drug addictions, RH sensitives, pulmonary disease, bleeding, tendency, surgeries, and anesthetic complications, previous abdominal pap test, infertility problems, sexual transmitted infections, and drug allergies. In addition, the medical assistant facilitates information from the patient. Come on, Ashton, stop. Regarding immunizations and childhood diseases to provide the provider with the information needed to to assist her antibody protection against such diseases.
Very good. Thank you, thank you, thank you. Okay, so I just want you to highlight that first part where it says the past medical history focuses on conditions that could affect the health of the mother and fetus, such as diabetes, hypertension, heart disease, autoimmune disorders, kidney disease. All right, Jasmine, go ahead and read the next paragraph. Will you go ahead and wake your sister up and let her know that we'll be leaving here in a minute? Thank you, though.
Okay. Rubella is contracted during pregnancy. Rubella, if contracted during pregnancy, can be dangerous to a developing fetus. The earlier in pregnancy the infection occurs, the greater is the chance of birth defects. The infant may be born with heart defects, cataracts, mental retardation, and deafness. Patients who do not have antibody protection against rubella are given a rubella immunization within 6 weeks of delivery. The rubella vaccination cannot be given to a pregnant woman because it may be harmful to the fetus. These patients should be told to avoid exposure to children with rubella during their pregnancy.
Very good. All right, Lily, go ahead and read menstrual history.
Menstrual history is obtained from the patient. It includes the date of onset of menstruation, the menstrual interval cycle, the duration, the amount of flow, documented as small, moderate, or large, and any gynecologic disorders. The form also includes a space for the patient to indicate whether or not she was using a method of contraception when she became pregnant.
All right, very good. So I want you to highlight the second sentence, please. Obstetric history. A thorough obstetric history is a component of the prenatal record and provides the opportunity to obtain information from the patient related to previous pregnancies. Information that is obtained and explored includes gravidity, parity, and other information related to previous pregnancies. Gravidity and parity provide data with respect to the pregnancy, and the medical assistant should develop skill in documenting this information. Gravidity, G, is documented using one digit, which indicates the number of times a woman has been pregnant, regardless of the duration of the pregnancy and including the current pregnancy. Highlight that. A woman who is pregnant for the second time but had a spontaneous abortion during the first pregnancy would be documented as G2. A woman who is pregnant for the second time and did not have a spontaneous abortion also would be documented as G2. Parity refers to the condition of having born offspring regardless of the outcome. Highlight that sentence. It is documented using 4 abbreviations and digits which present in the following pregnancy outcomes. Number 1, T for term birth. Delivery after 37 weeks regardless of whether the child was born alive or stillborn. Number 2, preterm birth. Delivery between 20 and 37 weeks regardless of whether the child was born or alive or stillborn. Abortion. Termination of the pregnancy before the fetus reached the age of viability, 20 weeks. An abortion can be spontaneous or elective. Living children. Number of living children. Example, a woman who has been pregnant 4 times with the following outcomes: a spontaneous abortion, a full-term stillbirth, a preterm baby of a healthy child, and a full-term birth of a healthy child. The documentation would be as follows: G4, T2, P1, A1, 2, L2. Highlight that. So you're going to want to highlight 1, 2, 3, 4, and the example for number 4. Multiple births, twin triplets, count as 1 pregnancy and 1 delivery. If a woman had been pregnant 2 times and had a set of full-term healthy twins and a set of preterm healthy triplets, the documentation would be G2, T1, P1, A0, L5. If a woman is a multigravidia, information about each pregnancy is obtained, including the date of delivery, gestation in weeks, length of labor in hours, birth weight and sex of the newborn, type of delivery, vaginal or cesarean section, type of anesthesia, and any maternal or infant complications. The obstetric history assists in identifying areas that may need to be investigated further or monitored during the prenatal period. Women with previous complications such as premature labor, gestational diabetes, or postpartum hemorrhaging are at risk for having these problems again. All right, Nancy, go ahead and read the first paragraph under present pregnancy history.
The present pregnancy history establishes the baseline present health status of a prenatal patient. In addition, the patient is inquired regarding any warning signs that may be present and that may place the mother or fetus in jeopardy, such as persistent headaches, visual disturbances, abdominal pain, vaginal bleeding, or discharge. The patient also is asked whether she has experienced any of the early signs of pregnancy, such as nausea, vomiting, fatigue, and breast changes.
Very good. I want you to highlight all of that first paragraph. All prescribed or over-the-counter medications, including vitamin supplements and herbal products the patient is taking, must be documented. Highlight that sentence. Certain medications cross the placental barrier and could be harmful to the developing fetus. The patient should be instructed not to take any medications without first checking with the provider. In the space provided under the present pregnancy history, the medical assistant needs to document the date of the first day of the patient's last menstrual period, LMP. Highlight that. Highlight that the LMP is used to calculate the due date or expected date of delivery, EDD, by using Nagel's rule. Subtract 3 months from the date of the LMP, add 7 days, and add 1 year. Highlight EDD equals LMP minus 3 months plus 7 days plus 1 year. For example, if the date of the patient's LMP was June 10th, 2018, the EDD is March 17th, 2019. The problem is set up as follows. All right, so we've got 6/10/2018, which is the last menstrual period, we minus 3 months, add 7 days, add 1 year, applying the Nigel rule, then the expected date of delivery is March 17th, 2019. Any questions on that?
That always sounded so confusing to me, but I'm looking at it now and it's not that confusing.
No, it's not. When you're having to, because of the way that the words are used in this, it does come across as confusing. I admit that. But then when you kind of look at it, basically you just take the patient's last menstrual period minus 3 months, add 7 days, and then add 1 year, which is 365 days. And then that would give you your delivery date, so to speak.
Nice.
No. Using Nigel's rule, approximately 4% of patients deliver spontaneously on the EDD. Most patients deliver during the period extending from 7 days before to 7 days after the EDD. Gestation calculators are commercially available that can be used to determine the delivery date by lining up an arrow and the date of the LMP using a movable inner cardboard wheel, figure 8.12. And I will tell you that I was so happy when they made this. It made my job that much easier. There are also many online gestation calculators available, as well as a variety of gestation calculator applications designed for mobile devices. In addition, electronic medical record software automatically calculates the EDD after the LNP has been entered in the computer. Gestation calculators require less time to determine the EDD than using Nigel's rule, and they provide information on the probable size, length, and weight of the fetus on any given date. The accuracy of gestation calculators is compared to that of the Nigel's rule. If the patient is unsure of the date of her last menstrual period, the provider estimates the length of gestation by other methods, such as fundal height measurement and sonography. All right, have I lost any of you yet? All right, good. Sabrina, go ahead and read the first and second paragraph on the interval prenatal history.
The interval prenatal history also is included in the prenatal record form. Its purpose is to update the record. During every return visit, essential data including weight, blood pressure, urine testing results, fundal height measurement, and fetal heart rate are collected and documented in this section. A general inquiry is made regarding the occurrence of additional signs of pregnancy, such as fetal movement or Braxton Hicks contractions, and how the patient is feeling, and any concerns or symptoms since the last prenatal visit. This information is documented and assists the medical staff in planning, implementing, and evaluating individual needs. Particular attention is focused on risk factors such as hypertension, thrombophlebitis,
Thrombophlebitis, yep.
and uterine bleeding, which would influence the course of the pregnancy.
All right, very good. So in the first paragraph, I want you to highlight that during every visit, essential data including weight, blood pressure, urine testing results, fundal height measurement, and fetal heart rate. Also highlight the words additional signs of pregnancy and highlight where it says any concerns or symptoms since the last prenatal visit. All right, very good. Talia, go ahead and read all of initial prenatal examination under purpose.
The initial prenatal examination is of particular importance because it results in confirmation of the pregnancy and establish a baseline for the woman rate states of health. It includes a throughout gynecologic examination, breast and pelvic examination, and a general physical examination of the body system. All through the latter may be performed during a subsequent prenatal visit, depending on the medical office routine. Women often have little or no medical supervision during their childbearing years. The physical examination is of particular importance in establishing a baseline for the women's general rate of health and identifying high risk prenatal patients. Conditions such as obesity, hypertension, cerebral varices,
Very
and urine
precise.
very size and urine size inappropriate treat for the due date can be not diagnosed by the provider and necessary treatments or monitoring can be instituted to help prevent complications.
All right, very good. Thank you. All right, Alicia, go ahead and read all of preparation of the patient.
When the patient arrives at the medical office and the prenatal record form has been completed, the medical assistant is responsible for taking and documenting the patient's vital signs, height, and weight to provide a database for subsequent prenatal visits. The patient is asked to disrobe completely and put on an examining gown with the opening in the front. The medical assistant must give complete and thorough instructions to the patient so that the patient knows exactly what is expected. The patient should be asked whether she needs to empty her bladder because an empty bladder facilitates the examination and is more comfortable for her. If the office policy is such that a specimen is needed for the urine testing at the initial prenatal visit, the patient will be required to void. Special precautions should be taken in assisting the prenatal patient. The medical assistant should support the patient as she gets onto and off the scale and examining table to ensure her safety and comfort. This is especially important as the pregnancy progresses and the patient becomes more awkward and off balance. The medical assistant is responsible for setting up the tray required for the examination. The setup includes the equipment and supplies required for the procedures to be performed. During the prenatal examination, the medical assistant is responsible for positioning the patient as required for each aspect of the examination and assisting the provider as necessary. Table 8.2 lists the procedures commonly included in the prenatal examination, the purpose, the implications, and when applicable, the patient's position. Most of the procedures included in the initial prenatal examination are presented elsewhere in this text. The number of the chapter that contains the step-by-step procedure is included in Table 8.2.
All right, very, very good. All right. Anna, go ahead and read patient education.
Come here. Come here.
Do you want to hold off, Anna?
Now he's in my lap now. He should be okay.
Okay.
At the conclusion, you want me to read all of it or just a paragraph?
Go ahead, do all of it, please.
Okay. At the conclusion of the initial prenatal examination, after the patient is dressed, the provider talks with her regarding instructions on diet, weight gain, rest, sleep, employment, exercise, travel, sexual intercourse, dental care, smoking, alcohol, and drugs. Many offices have a prenatal guidebook designed especially for this purpose that is given to each patient to use as a reference. Some offices also use a series of teaching films that the patients use during the return prenatal visit while waiting to see the provider. The provider also prescribes a daily vitamin supplement to be taken during the prenatal period to ensure that the mother and the fetus obtain an adequate supply of vitamins and minerals. When the provider is finished talking with the patient, the medical assistant is responsible for scheduling the next prenatal visit for ensuring that the patient understands that the instruction of maintaining health and preventing disease during this pregnancy. The medical assistant should tell the patient to report the occurrence of any warning signs during the pregnancy. See the box warning signs during pregnancy and not to take any medication without checking with the provider. The patient also should be encouraged to contact the medical office should any questions or problems arise.
Perfect. All right. Let's see. Jasmine, go ahead and read all of the laboratory tests.
The provider orders many laboratory tests to assist in the assessment of the patient's state of health and to detect problems that may put the pregnancy at risk. Several tests, such as the Pap test and the chlamydia and gonorrhea test, require the provider to collect the specimens at the medical office and have them transported by laboratory courier to an outside laboratory for evaluation. The specimen required for the prenatal blood test, known as a prenatal profile, must be obtained through a venipuncture to provide a sufficient quantity of blood for the number of tests ordered. The blood specimen is collected at the medical office or at an outside laboratory. It is important to have these initial tests completed as soon as possible to provide the provider with the test results by the time of the next scheduled prenatal visit. Based on the results of the prenatal examination and the laboratory tests, the provider may order additional tests to assess the patient's condition. Certain tests and procedures, such as the glucose challenge test, GCT, and the Group B Streptococcus GBS test, are scheduled later in the pregnancy. The prenatal laboratory tests that are usually performed on a pregnant woman are described next.
All right, very good. So really quickly, I want you guys to look at the table 8.2 on page 264. I want you to highlight where it says vital signs, physical examination, breast examination, and pelvic examination. On page 265, where it says the warning signs during pregnancy, I want you guys to highlight vaginal bleeding and abdominal pain, blurred vision, and I want you to make a note that heartburn is normal. All right, urine test, urinalysis. A complete urinalysis, including physical, chemical, and microscopic analysis of the urine, is performed. A clean catch midstream urine specimen is generally required for the test. If bacteria are found in the urine specimen, the provider usually requests a urine culture and sensitivity test to determine the possible presence of the urinary tract infection. A pregnancy test also may be performed on the urine specimen if ordered by the provider. Swab test. Pap test. A Pap test is done for the detection of abnormalities of cell growth to diagnose precancerous and cancerous conditions of the cervix. This test can also be used for hormonal assessment, maturation index, and to assist in the detection of vaginal infections. Chlamydia and gonorrhea. Specimens are taken from the endocervical canal and sent to the laboratory to rule out chlamydia and gonorrhea. Chlamydia can be passed from an infected woman to her infant during childbirth, resulting in conjunctivitis and pneumonia in the newborn. If a gonorrheal infection is present at the time of delivery, the N-gonorrhea organism could infect the infant's eye during passage through the birth canal. This may result in ophthalmia neonatorum, which is not treated, could lead to blindness. All right, I want you to highlight that sentence, the last two sentences. For this reason, most states require that pregnant women be tested for gonorrhea and that the eyes of newborns be treated with antibiotic drops immediately after birth to kill any gonococcal bacteria that may be present. A patient who is diagnosed with chlamydia or gonorrhea requires immediate treatment with an appropriate antibiotic to prevent problems for herself and her child. Trichomoniasis and candidiasis. If an excessively irritating vaginal discharge is present, the provider obtains a specimen to rule out trichomoniasis and candidiasis. It is important to control candidiasis before delivery to prevent the development of thrush and yeast-like infection of the infant's mucous membranes of the mouth and throat. Group B Streptococcus. Group B Streptococcus GBS is a common bacterium often found in the vagina and rectum of a healthy woman. Normally, 1 in 4 pregnant women carries GBS. GBS is not harmful to a pregnant woman, but it can cause life-threatening infections in a newborn. While passing through the birth canal, a newborn can become infected with the bacteria carried by the mother. Highlight where it says, when infected, the infant may develop an infection of the blood, septicemia, pneumonia, or meningitis. To prevent GBS infection of the newborn, highlight a pregnant woman is tested for the bacterial between 35 and 37 weeks of gestation. Using 2 swabs, the provider collects specimens from the vagina and the rectum. The specimen swabs are placed in a transport tube and sent to the laboratory to be cultured for GBS. If GBS is found, intravenous antibiotics are administered to a woman every 4 hours during labor until delivery. In most cases, this antibiotic administration prevents the newborn from becoming infected with GBS. In situations in which the newborn does become infected with GBS, antibiotics are administered immediately and the infant is closely monitored. GBS testing is very, very common now. All right, any questions so far? You're doing good, guys. We're almost all done. We're just about at that mark.
So
Okay.
GBS is healthy. It's not like a disease or anything like that.
Well, so GBS is a bacteria that it can become dangerous, but it's not in the same category of like chlamydia and gonorrhea.
Okay.
So some people can carry the strep bacteria and never know it, but because of that, for the mother and the infant, it can both be dangerous. So that's why it's more now of a common test. Like my sister-in-law, and I've had other members of my family that would had to have the IV antibiotics every 4 hours before labor, and then the baby was treated as well. And a lot of times they think that because it doesn't really affect the mother per se, it's mostly the infant that gets affected. But if they can treat the mother while she's still carrying the child, then that helps. Treat it so that way they don't actually have to treat the infant. All right, case study number 3. Joanna Gruger is 24 years old and pregnant with her first child. She is at the office for her first prenatal visit. She is quite upset. Her best friend just had her first baby, and the baby died 24 hours later from the group B strep infection. Joanna is afraid that the same thing will happen to her baby. She wants to be tested for GBS as soon as possible. She has some antibiotics at home and is thinking of taking them. Joanna is worried because she has been experiencing some problems with her pregnancy. She is sick all day, her breast hurt, and yesterday she had some spotting. Joanna is hesitant to tell all of this to the physician because he might think she worries too much. All right. So, what would you do?
You would tell her that she can get tested for the GBS at 35 or 37 weeks, and that taking the antibiotics wouldn't be the best thing for her or the baby.
Very good.
You can tell her to express all her concerns to the provider and to let her know that she isn't going to be judged or be told that she worries too much about it.
That's right. Very good.
Also, you should inform her that she should not take any antibiotics that she has at home because she's not prescribed to them at this very moment. So they're not good to take.
That's right, because now she's pregnant. So some antibiotics, that may have been fine for her to take before she was pregnant may not be fine while she's pregnant. It can harm the baby. All right, very good. Anything else that we could tell her? Alexis, that's right. Tell her she doesn't worry too much. She's just concerned, which is fine. That's right.
She's at the office for her first prenatal visit, and you should explain to her that her being sick all day, her breast hurting, are common symptoms of, the beginning of pregnancy.
That's right. Yep, that can be very normal, but we're going to go and let the provider know. Yep, very good. Okay, well, what about the GBS? So her friend's baby died 24 hours after giving delivery, and she wants to know, she wants to be tested right away. So how do we handle as far as that part?
Can you be tested early?
You can, but they generally do not test until your third trimester.
I would just say inform her as to when, you know, she will be tested. Um, but I do think that one thing a medical assistant should never do is probably say that it's not going to happen. We probably don't even want to mention that because we don't know what could
That's
happen.
right. That's a very, very good point, Nancy. So, just like we're not going to tell a child when we stick them with a needle that it's not going to hurt, that is lying to the patient, and we do
Correct.
not know if it's going to cause discomfort. Same thing with this incident. We cannot guarantee that it will not happen to their child. We also can't guarantee that anything else won't affect her or her child. But what we can do is provide her with the information that we do know. So, we do test. Assure her that that is part of a routine testing that we do during such and such time of your pregnancy. We're going to continue to monitor you at your prenatal visits. And if you have any questions or concerns, please don't hesitate to give me a call. Let her know that you are there for her. The way she feels is completely normal.
And I think at any time, when there's any like concern and like her going through that emotional stage, I think sympathizing a lot with the patient usually eases their concern.
It does. It does. And that is actually a pretty good answer to most of the scenarios you will find with your patients. Just listen to them. Show that you care. Show that you're listening and that, you just, you can relate on their level as much as possible. And sometimes you may not be able to, but that still isn't going to stop us from listening to them and giving a medical assistant point of view, and definitely not diagnosing them, but that we are here for them. I can tell you that I know my OBGYN's medical assistant by name, and if I have questions, that's who I call. I'd rather talk to her than my doctor. My primary care doctor, I know her name because I've dealt with her over the years. Same thing. And a rheumatologist, I know her nurse's name. You will come to find out that your patients will relate and want you to talk to more than their provider. So being a medical assistant is a core in this field. All right, any questions? All right, let's go on to page 266. All right, so now we have blood test. So you're going to find that you're going to hear the name of these blood tests throughout the other chapters. All right, so complete blood count. The complete blood count, CBC, is a basic screening test used to assist in assessing the patient's state of health. It includes hemoglobin, hematocrit, white blood cell count, red blood cell count, differential white blood cell count, platelet count, and red blood cell indices. Of particular importance with respect to the prenatal patient are the hemoglobin and hematocrit evaluations, which are described here. Hemoglobin and hematocrit. Low hemoglobin or hematocrit values are seen in cases of anemia. Prenatal patients have a tendency to develop anemia because there is an increased demand for and correlating increased production of red blood cells during pregnancy. The provider carefully reviews the results of these tests. If the hemoglobin or hematocrit value is low, further hematologic evaluation is usually required. If necessary, therapy is instituted, which usually consists of iron supplements and nutritional counseling. The hemoglobin and hematocrit values are checked again at approximately 32 weeks of gestation as a precaution against anemia before delivery. So what would happen if we did not check the patient's hemoglobin and hematocrit values at 32 weeks?
They could develop. It says red blood cells during pregnancy.
Right. So if the patient is already experiencing some anemia in the early part of the pregnancy or even throughout the pregnancy, when the mother gives birth, what could be something that could happen?
I want to say blood.
Right. The patient could need blood. So if she's not producing enough red blood cells and she goes into labor and we don't already know what's going on, she's not going to have a normal delivery. She is going to come across some serious complications. All right, very good. Rh factor and ABO blood type. Tests are performed to anticipate ABO blood type and Rh factor incompatibilities. If the patient is Rh negative, the possibility of an Rh incompatibility exists. The situation warrants the performance of an Rh antibody titer test and repeat antibody titers throughout the pregnancy to determine whether the mother's antibody level is increasing. An increased Rh antibody level could be dangerous to developing fetus. It can result in severe anemia, jaundice, brain damage, heart failure, and sometimes the death of the fetus. Yep, Alexis, bleed out. That's right. All right, glucose challenge test. I hate this test. A glucose challenge test is performed between 24 and 28 weeks of gestation to screen for gestational diabetes mellitus, GDM. The test works by assessing the body's response to a measured glucose solution. The patient does not need to fast for this test, and no preparation is required other than arriving at the laboratory at the scheduled time. To perform the glucose challenge test, the patient is asked to drink 50 grams of a glucose solution, and her glucose level is measured 1 hour later. A woman with a glucose level of less than 140 milligrams does not have GDM and requires no further testing. If the glucose level is greater than 140 milligrams, the test is abnormal. Not all women with elevated results have diabetes, however, and further testing using the 3-hour oral glucose tolerance test, OGTT, must be performed before a final diagnosis can be made. Note, refer to Chapter 19 for information on the OGTT. All right, the syphilis test. The microorganism that causes syphilis, Treponema pallidum, is able to cross the placenta barrier and infect the fetus. This could result in intrauterine death or could cause the fetus to be born with a congenital syphilis. Infants with congenital syphilis are often born with deformities and become blind, deaf, paralyzed, or insane. The tests most commonly employed to screen for the presence of syphilis are the Venereal Disease Research Laboratory, VDRL test, and the Rapid Plasma Reagin, RPR test. The test results are reported as non-reactive, weakly reactive, or reactive. Because these tests are screening tests, a weakly reactive or reactive test warrants result warrants more specific testing to arrive at a diagnosis for syphilis. Example of these tests are the fluorescent treponemal antibody absorption FTA-ABS test and the Tripomonia pallidum particle agglutination assay TPPA test. Goodness. A prenatal test for syphilis is mandated by most states and should be performed early in the pregnancy before fetal damage occurs. A patient who has contracted syphilis requires treatment with an appropriate antibiotic. All right, rubella antibody titer. The rubella antibody titer assesses the level of antibody against rubella, German measles, in the patient's blood and is used to determine whether the woman is immune to rubella. If the mother contracts rubella during pregnancy, serious congenital abnormalities can occur in the fetus. Patients who lack immunity should be immunized against rubella within 6 weeks of delivery. Okay, Rh antibody titer or on Rh negative blood specimens. An Rh antibody titer detects the quality of circulating Rh antibodies against red blood cells. These antibodies can occur in a pregnant woman who is Rh negative and is carrying an Rh positive fetus. An Rh antibody titer is performed on all Rh negative blood specimens. Repeat antibody titer levels are also performed during the pregnancy to determine whether the woman's antibody level is increasing. As previously indicated, an increased Rh antibody level could be dangerous to a developing fetus. As a preventative measure, Rh negative women with the potential of having an Rh positive infant and who test negative for Rh antibodies are given 2 injections of Rh immune globulin, the RhoGAM. The Rh immune globulin prevents for the formation of Rh antibodies in the mother, which avoids Rh incompatibility complications during the next pregnancy. The first injection is given at 28 weeks of gestation, and the second injection is administered within 72 hours of delivery. All right. Hepatitis B and human immunodeficiency virus. The Center of Disease Control and Prevention, CDC, recommends that pregnant women have the hepatitis B surface antigen test to screen for hepatitis B virus. Women who have positive HBsAg test results have an increased risk of spontaneous abortion or preterm labor. In addition, the mother may transmit hepatitis B to the infant, particularly during delivery or in the first few days of life. The risk can be greatly reduced by administering hepatitis B immunoglobulin and a hepatitis B vaccine within 12 hours of birth to the newborns of women who have tested positive for hepatitis B. Infants born to women who are human immunodeficiency virus positive are at risk of developing the disease. If antiretroviral drugs are taken during pregnancy and the infant is delivered by cesarean section, the chance of transmitting HIV to the infant is reduced significantly. Because of this, the CDC recommends that testing for HIV be included in the routine panel of prenatal screening tests for all pregnant women, and that separate written consent is not required. The CDC further recommends that the patient should be notified that HIV testing will be performed unless the patient declines the test. The CDC recommends that repeat HIV screening be performed in the 3rd trimester in geographic areas that have elevated rates of HIV infection among pregnant women. All right, return prenatal visits. Lily, go ahead and read that first paragraph.
Return prenatal visits provide the opportunity for a continuous assessment of the health of the mother and the fetus. During each visit, essential data are collected and documented in the prenatal record, resulting in an updated record at each visit, as it discussed in the section. If signs or symptoms of a ophthalmologic condition are present, the provider performs select aspects of the physical examination as necessary to diagnose and treat the condition. In addition, diagnostic and laboratory tests may be ordered to assist in diagnosis. The usual schedule of visits for prenatal care is listed below. A patient who exhibits complication is seen more frequently for closer monitoring. 0 to 28 weeks of gestation every 4 weeks, 29 to 35 weeks every 2 weeks, and 36 weeks until delivery every week.
All right, very good. I want you guys to highlight the first bullet point. All right, Nancy, go ahead and read the next paragraph, please.
The return prenatal visit also provides the opportunity for the provider and the medical assistant to lend. I am in the right spot, right?
Yes, you are.
The return prenatal visit also provides the opportunity for the provider and the medical assistant to lend support to the mother, to provide her with ongoing prenatal education, to reduce apprehension and anxiety, and to ensure that the mother is well informed and prepared during her pregnancy, childbirth, and the postpartum period. The medical assistant plays an important role in prenatal education and should take the necessary time with each patient to provide appropriate information and allow a patient to ask questions. Procedure 8.3 outlines the medical assistant's role in the return prenatal visit.
Awesome, thank you. All right, Sabrina, go and read the next paragraph, please.
The patient is asked to provide a urine specimen during each return prenatal visit. The medical assistant is responsible for testing the specimen for glucose and protein using a reagent strip and for documenting results in the prenatal record. A positive reaction to glucose may indicate the development of gestational diabetes, mellitus, or prediabetic pre-diabetic condition, and a positive reaction to protein may indicate a urinary tract infection or preeclampsia. Further testing usually is needed to arrive at a final diagnosis and to institute treatment. Hypertension is the most common medical disorder of pregnancy and occurs in 10% and to 12% of all pregnancies. Because of this, the medical assistant must make sure to obtain an accurate blood pressure measurement.
Very good. Okay, so you're going to highlight the first two sentences and where it says hypertension is the most common medical disorder of pregnancy and occurs in 10 to 12% of all pregnancies. All right, Talia, go and read the next paragraph, please.
During the return visit, the provider performs one of the more of the following procedures depending on the stage of the pregnancy. 1. Palpation of the woman's abdomen measured to fundal height. 2. Measure of the fetal heart rate. 3. A vaginal examination. These procedures are discussed in details next.
All right, fundal height measurement. The pregnant uterus rises gradually into the abdominal cavity, and the fundus is palpable between 8 and 13 weeks of gestation. The first fundal height measurement, which is usually performed during the first prenatal visit, is used as a guideline for all subsequent measurements. The provider measures the fundal height by placing one end of a flexible, non-stretchable centimeter tape measure on the superior aspect of the symphysis pubis and measuring to the crest or the top of the uterine fundus. For example, in 8.13, the measurement is documented on a flow chart in the patient's prenatal record. By 20 weeks, the fundus reaches the lower border of the umbilicus, and between 36 and 37 weeks, it reaches the tip of the sternum. During the first and second trimesters, measuring the fundal height provides a rough estimate of the duration of the pregnancy. The fundal height measurement is considered accurate to within 4 weeks using the McDonald's rule. Calculation of the duration of the pregnancy using McDonald rule is as follows. Height of fundus in centimeters times 8/7 equals duration of the pregnancy in weeks. All right, because of fetal weights vary considerably during the third trimester, it is difficult to use a fundal height measurement as an estimate of the duration of the pregnancy in the last trimester. Stop it. In addition to assessing the duration of the pregnancy, the fundal height measurements permit variations from normal to become apparent and are used to assess whether the fetal growth is progressively normal. Go and highlight that sentence, please. Stop. Growth that is too rapid or too slow must be evaluated by the provider as a possible indication of high-risk conditions, such as multiple pregnancies, polyhydramnios, ovarian tumor, intrauterine growth retardation, intrauterine death, or an error in estimating the fetal progress. Alicia, go ahead and read the next paragraph.
The normal fetal heart rate is between 120 and 160 beats per minute with a regular rhythm. A very slow or rapid fetal heart rate usually indicates fetal distress. The term fetal heart tones refers to the heartbeat of the fetus as heard through the mother's abdominal wall. The fetal heart tones can be heard with a Doppler fetal pulse detector between 10 to 12 weeks of gestation. The Doppler fetal pulse detector converts ultrasonic waves into audible sounds of the fetal pulse.
Very good. Okay, you're going to highlight the first sentence. And where it says the fetal heart rate tones can be heard with a Doppler fetal pulse detector between 10 to 12 weeks of gestation. All right. Anna, go and read the next paragraph, please.
The Doppler device consists of a main control unit and a probe. Figure 8.15a. The probe head contains a transducer and an electronic component which generates the sound waves. The probe head is delicate and must be handled carefully, making sure not to drop or knock the head to prevent damaging it.
Very good. Jasmine, go and read the next paragraph.
Because air is a poor conductor of sound, an ultrasound coupling gel must first be spread on the mother's abdomen in the area to be examined. The gel is usually applied by the medical assistant, and its purpose is to increase conductivity of the sound waves between the abdomen and the transducer.
Very good. Lily, go and read the next paragraph.
The provider places the head of the probe into the gel on the mother's abdomen and slowly moves it until the fetal heart tones are located. The Doppler device amplifies the fetal heart tones. They are broadcast through a built-in loudspeaker in the main unit. A volume control provides adjustment of the sound level as required. Fetal heart tones sound like the hoofbeats of a galloping horse, and the probe is over the placenta. A wind-like sound is heard. The Doppler device also may have a LCD screen which provides a digital display of the fetal pulse rate. Stereo headphones come with the Doppler device to allow private listening. The loudspeaker is muted when the headphones are connected.
Very good. Nancy, go and read that next paragraph.
After the procedure, the medical assistant removes excess gel from the mother's abdomen with a paper towel. The probe head is cleaned using a damp cloth or a paper towel. The Doppler device should be properly stored in its carrying case to prevent it from becoming damaged.
All right, very good. Vaginal examination. In the absence of vaginal bleeding, vaginal examination may be performed at any time during the pregnancy. However, in a normal pregnancy, there is usually no need to perform a vaginal examination until the patient nears term. The vaginal examination is usually begun approximately 2 to 3 weeks from the EDD and is performed to confirm the presenting part and to determine the degree, if any, of cervical dilation and effacement. Highlight that sentence. The purpose of dilation and effacement is to permit the passage of the infant from the uterus into the birth canal. Case study number 4. Juanita Lopez is at the office with her husband. She is 32 years old and 18 weeks pregnant. It took Juanita a long time, almost 6 years, to get pregnant. She is excited and happy about being pregnant, but at the same time sad and confused. Her test results on her multiple marker test came back indicating the possibility that her baby has Down syndrome. A repeat test was done with the same results. Juanita just got finished having an ultrasound that showed a normal baby, but Juanita and her husband understand that the only way to know for sure is to have an amniocentesis. Juanita does not know what to do. She is afraid of having an amniocentesis because of the chance of miscarriage. She also knows that her multiple marker test could be a false positive. Juanita is unsure about her decision and would be if the baby did have Down syndrome. Her husband is visibly distressed and wants Juanita to make all the decisions, saying he will be supportive of whatever she decides. Right now, she wants as much information as she can about all of this before she makes a decision. She feels safer being at the medical office and does not want to go home just yet. Okay. So has anyone heard of the word amniocentesis? And we're going to be covering it in just a little bit.
I have.
Okay, tell me about it.
I just saw it on Grey's Anatomy.
Okay.
They like stick that really long needle in the stomach into the baby. It takes some, I don't know if it's blood or what they take, but they get tested for it.
Yep.
Yeah, that's where I heard it too.
Yep. Very good. Yeah. So basically, that is amniocentesis. It is a scary procedure, especially for a new mom. But it can provide with accurate results of the child. So it can be very good. Okay, so with knowing that, let's start with what would you do?
Wait, can you repeat that again?
What is it? I'm sorry?
I said, can you repeat it, your question again?
Oh, yeah. So with knowing of the concept of the amniocentesis, what would be, as a medical assistant, what do you do? So what would you do with this case study?
Probably just try to provide her with as much information as possible for her to be able to make a decision.
Mm-hmm. Good. What would we not want to do?
I kind of want to say we don't want to advise her as far as how we would handle it, or like our personal view.
That's right. That is absolutely correct. So we will not, this is a good example of when we're not going to recommend anything. We are literally going to advise our patient that we do understand that, I'm sure she's scared, right? I would be terrified. But here's information on everything, and, we're going to let the provider know so the provider can also give you as much information as possible. So that way she would be more comfortable about making a decision, right?
Right.
All right, very good. So special tests and procedures. The pregnancy can be evaluated with one or more of the following tests and procedures: a multiple marker test, obstetric ultrasound scan, amniocentesis, and fetal heart rate monitoring. These are not considered routine procedures. However, they involve little or no risk to the mother or the fetus. Because some of the tests may be performed in the obstetric medical office, the medical assistant should have a general knowledge of these procedures. All right, the multiple marker test. Alexis, go ahead and read that first paragraph. All right, Alicia. Oh, okay. Thank you, Alexis. That's fine. Yeah, Alicia, go ahead and read that first paragraph.
You said multiple marker test?
Yes.
Okay. The multiple marker test is a laboratory test available to pregnant women between 15 and 20 weeks of gestation. Its purpose is to screen for the presence of certain fetal abnormalities, which include neural tube deficits, Down syndrome, trisomy 18, ventral wall defect. Because the multiple marker test has a high incidence of false positive test results, it is not a mandatory prenatal test. However, the American College of Obstetricians and Gynecologists believe that this test should be offered to all pregnant women regardless of maternal age.
Very good. Okay, I want you to highlight where it says its purpose is to screen for the presence of certain fetal abnormalities, which include neural tube defects. All right. Anna, go ahead and read the next paragraph.
The multiple marker test measures the level of 3 or 4 of the following substance normals produced by fetus in the placenta and extracted into the mother's blood in the second trimester of pregnancy. I'm gonna need help with these words.
That's okay. All right. So we have alpha fetoprotein, unconjugated estriol, human chorionic gonadotropin, and inhibin A. And if that's wrong, it might be wrong, but that's the way I pronounce them. All right. Good job. Jasmine, go ahead and read the next paragraph, please.
If the multiple measures the level of the first three substances outlined above, it is known as a triple screen test. If the measurement of the fourth substance, inhibin A, is added to the test, it is known as a quadruple screen test. The quadruple screen test appears to be more accurate than the triple screen test in detecting the presence of Down syndrome. AFP is a glycoprotein produced by the fetus. During pregnancy, some AFP crosses from the amniotic fluid into the mother's bloodstream. When the neural tube of the fetus is not properly formed, increased amounts of AFP appear in the maternal blood. Elevated AFP levels indicate the possibility of a neural tube defect in the fetus, such as spina bifida, incomplete closure of the spinal column, and anencephaly, incomplete closure of the brain.
Very good. All right. Lily, go ahead and read the next paragraph, please.
A lower serum level of AFP and estriol, along with a higher level of HCG and inhibin A, is associated with an increased risk of having an infant with Down syndrome. A woman who is carrying a fetus with trisomy 18 may have lower blood levels of AFP, estriol, and HCG than women with uninfected fetuses. The multiple marker test is a screening test. Abnormal test results always require further testing, such as an ultrasound or amniocentesis, to determine whether a fetal abnormality actually exists.
All right. Obstetric ultrasound scan. An obstetric ultrasound scan is a diagnostic imaging technique similar to sonar used to view the fetus in utero. It allows continuous viewing of the fetus and shows fetal movement. An ultrasound technologist usually performs the procedure. Highlight: the primary purpose of the ultrasound scan is to evaluate the health of the fetus and determine gestational age. This is accomplished by viewing the image of the fetus and by taking various measurements of the image, such as crown, rump, length, biparietal diameter, which is a side-to-side measurement of the fetal head, femur length, and abdominal circumference. An extronic ultrasound scanning uses high-frequency sound waves that are directed into the uterus through a transducer. When the sound waves reach the uterus, they bounce back to the transducer, similar to an echo. These reflected sound waves are converted onto an image, or sonogram, which is displayed on a monitor screen. The monitor is usually positioned so the mother can observe the image on the screen if she wishes. There are two methods for performing an ultrasound scan: a transabdominal method and an endovaginal method. Although an obstetric ultrasound scan can be performed at any time during the pregnancy, it is often performed between 7 and 12 weeks of gestation, and again between 18 to 20 weeks. A third scan is sometimes done around 34 weeks of gestation. Box 8.3 outlines a schedule and what can be assessed at these times. Transabdominal ultrasound scan. Transabdominal ultrasound is the scanning method performed most often. The patient must have a full bladder for this examination. This is accomplished by instructing the patient to consume 32 ounces of fluid approximately 1 hour before the procedure. Highlight that sentence. A full bladder acts as an acoustic window through which the sound waves can travel to provide a clear visualization of the uterus. In addition, a full bladder holds the uterus stable and pushes any bowel movement that might interfere with the image. The patient lies on the examining table in a supine position and is draped with the abdomen exposed. A coupling agent in the form of a liquid gel is applied to the patient's abdomen to increase the transmission of the sound waves. An abdominal probe containing a transducer is placed onto the gel, and the probe is moved slowly over the patient's abdomen. The image of the fetus is displayed on the screen of the monitor. Three-dimensional and four-dimensional, 3D and 4D ultrasound scans are types of transabdominal ultrasounds. A 3D ultrasound exam takes thousands of images at once. These images are formatted into a 3D image which looks more lifelike. A 4D image is similar to a 3D image, but it also shows movement. Endovaginal ultrasound scan. In the early stages of the pregnancy, up to 12 weeks, endovaginal scanning is preferred over transabdominal scanning. The patient must have an empty bladder for the scan, which makes the examination more comfortable. The patient is placed in the lithotomy position, and a vaginal probe is placed in the patient's vagina. The image of the embryo is displayed on the screen of the monitor. An endovaginal ultrasound scan provides clearer visualization of the uterus at the beginning of the pregnancy because the probe is situated in the vagina, which places it closer to the uterus. Amniocentesis is a diagnostic procedure that can be performed between 15 and 18 weeks of gestation. Amniocentesis aids in prenatal diagnosis of certain genetically transmitted errors of metabolism, congenital abnormalities, and chromosomal disorders such as Down syndrome. It is also used to detect fetal jeopardy or distress and, later in pregnancy, to assess fetal lung maturity. Amniocentesis also can determine whether the fetus is a boy or a girl. Highlight those sentences. To perform the procedure, the provider inserts a long, thin needle through the mother's abdomen and into the amniotic sac surrounding the fetus. An obstetric ultrasound scan is always performed in conjunction with the amniocentesis so that the provider can view the position of the fetus, placenta, and amniotic fluid. This allows the provider to know the exact place to insert the needle. The provider withdraws a sample, about 1 tablespoon of fluid, which contains fetal cells. The fluid is sent to a laboratory for study. It usually takes 1 to 3 weeks to evaluate the amniotic fluid and report the results. Although the complication rate for an amniocentesis is extremely low, the procedure is not risk-free. There is slight risk of bleeding, leakage of fluid, and infection of the amniotic fluid. There is also a slight possibility of miscarriage. Because of these risks, amniocentesis is offered only to women whose pregnancies are at risk for fetal abnormalities. This includes women who are 35 years old or older, women who have a child with a genetic or neural tube defect, women who have had abnormal multiple marker test results, women who have or whose partner has a chromosome abnormality, and women who are or whose partner is carrier for a metabolic disease. All right, on page 272, I want you to highlight the second and third bullet point under between 7 and 12 weeks. Highlight in that picture where it says 9 weeks of gestation. What? I want you to highlight the first and second bullet point between 18 and 20 weeks. Fetal heart rate monitoring. Nancy, go and read the first paragraph.
Fetal heart rate monitoring is performed later in the pregnancy to obtain information on the physical condition of the fetus. Specific conditions that may warrant this procedure are fetal growth that is not progressing well, decreased amniotic fluid, decreased fetal activity, elevation of the mother's blood pressure, gestational diabetes, and an overdue infant.
Very good. I want you to highlight that last sentence. All right, Sabrina, go ahead and read the next paragraph, please.
To perform the procedure, an electronic microphone is strapped to the mother's abdomen to amplify the fetal heartbeat. A gel is usually applied under the microphone to make the sounds clearer. The fetal heartbeat is heard and displayed on the screen and printed on special paper.
All right, very good. Talia, go ahead and read the next paragraph.
There are two kinds of fetal heart rate monitoring procedures, the non-stress test and the contraction stress test. The non-stress test, NST, monitors changes in the fetal heart rate in response to the fetal spontaneous movements. The mother is instructed to press a button when she feels the fetus move. In a normal test, the fetus heart rate increases when the fetus moves. Within 2 hours of the procedure to stimulate fetal movements.
All right, very good. Alicia, go ahead and read the next paragraph, please.
If the results of the non-stress test are abnormal, a contraction stress test (CST) may be performed. This test is similar to the non-stress test, except the mild contractions of the uterus are stimulated for a short period of time. The contraction stress test is used to evaluate the response of the fetus's heart rate to the contractions to determine whether the fetus would be able to withstand the stress of repeated contractions during labor. If the results of the test are abnormal, further evaluation is required to evaluate the well-being of the fetus and to determine how and when the delivery of the fetus should be carried out.
All right, very good. All right. Medical assisting responsibilities. The medical assistant has many important responsibilities in the return prenatal examination, which are outlined in Procedure 8.3. The medical assistant is responsible for assembling the equipment and supplies required for the examination, for obtaining information to update the prenatal record, for preparing the patient for the examination, and for assisting the provider during the examination. The provider depends on the medical assistant to have the urine test results and certain measurements, such as blood pressure and weight, completed and documented in advance to allow him or her the opportunity to review these measurements before examining the patient. All right, let's go on over to page 277. Anna, go ahead and read the first paragraph under 6 weeks postpartum.
How do you say that?
Puerperium.
The period premium includes the period of time in which the body systems are returning to their pre-pregnant or nearly pregnant pre-pregnant state, which usually is 4 to 6 weeks after delivery. During this time, numerous changes occur in the woman's body. The involution of the uterus, the process by which it returns to its normal state and normal size and state occurs. This includes healing of any injuries sustained at the birth canal during the delivery. You're muted.
Sorry, the dogs are barking. Highlight the first sentence. And then Jasmine, go ahead and read the next paragraph, please.
During the how do you say that?
During the puerperium.
Puerperium, the patient experiences a vaginal discharge shed from the lining of the uterus, known as lochia. Lochia consists of blood, tissue, white blood cells, mucus, and some bacteria. The color of the lochia is an indication of the progress of the healing of the uterus. For the first 3 days after delivery, the lochia consists almost entirely of blood, and because of its red color, it is termed lochia rubra. By approximately 4 days postpartum, the amount of blood decreases and the discharge becomes pink or brownish and is known as lochia serosa. By 10 days postpartum, the flow should decrease and the lochia should become yellowish white. This is known as lochia alba. Lochia usually continues in consistently decreasing amounts from moderate to scant to occasional spotting and becomes paler in color until the 3rd week after delivery, when it usually disappears altogether. It would not be considered unusual for the discharge to last the entire 6 weeks, however.
All right, very good. So I want you to highlight where it says, and the lochia should become yellowish white. This is known as lochia alba. All right, Lily, go ahead and read the next paragraph, please.
The patient should be instructed to contact the medical office under the following circumstances: if the amount of discharge increases rather than decreases, if the discharge is absent within the first 2 weeks after delivery, if it changes to red after having been yellowish white, which indicates bleeding, or if it takes on a foul odor, which indicates infection. Menstruation usually begins approximately 2 months after delivery in a non-nursing mother and 3 to 6 months after delivery in a nursing mother.
Very good. I want you to highlight that whole paragraph. All right, Nancy, go ahead and read the next paragraph, please.
During the puerperium, the patient should be encouraged to avoid fatigue, to avoid lifting heavy objects, and to consume a nutritious, well-balanced diet that helps maintain health and promote it is to evaluate the general mental and physical condition of the patient to ensure there are no residual problems from childbearing and to provide the patient with education regarding postpartum depression and methods of contraception and infant care. During this visit, the patient is Wired about problems or abnormalities, discharge, urinary or bowel function, and breastfeeding if she is nursing. This information is documented in a patient medical record.
All right, Sabrina, go ahead and read the next 2 paragraphs.
The postpartum visit provides an excellent opportunity for the medical assistant to instruct the patient in the technique for performing a breast self-examination and to educate her on the importance of returning to the medical office as needed for a Pap test. During the postpartum examination, the provider evaluates the patient's general mental status and physical appearance performs breast and pelvic examination and checks to determine whether the muscle tone has returned to the muscles of the abdominal wall. During the puerperium, atypical cells may be sloughed off into cervical and vaginal mucus as part of the normal healing process. Because of this, the Pap test is not included in the postpartum visit. If the patient has problems with hemorrhoids or varicosities, the provider discusses any further treatment required.
All right, very good. All right, Talia, go ahead and finish with the last 2 paragraphs.
Patient does not have any antibody protection to the rubella as has been evidenced through the prenatal laboratory test. She receives rubella immunization at this time if it was not administered in the hospital. In addition, hemoglobin and
Hemoglobin.
hemorrhagic determinations usually are performed on the postpartum patient to screen for anemia because of the blood loss during delivery and puerperium. Something.
All right, responsibilities of the medical assistant during the postpartum visit include measuring and documenting the patient's vital signs and weight and preparing the patient for examination. The patient is required to disrobe completely for this examination and to put on an examining gown with the opening in front. Table 8.3 lists the procedures commonly included in the 6-week postpartum visit and the purpose of each. I want you guys to look at the table 8.3. And I want you to highlight under the procedure side where it says vital signs, breast examination, pelvic examination, and rectal vaginal examination. All right, and then I want you guys to look in your binder real quick. You guys should just have a diagram of the male and female reproductive systems, correct?
Yes.
Okay, good. So that's just used for you guys to kind of study by as part of learning the anatomy of the body, which is essential. So make sure you look over that. Make sure you do your Chapter 8 Evolve assignments. If you've not already sent me your Chapter 6 response, then please do so. And then if you've not sent me your Chapter 5, I need that as well. As soon as this uploads, I'll post it to the YouTube and I'll let you guys know. Make sure you go back in Chapter 8 and you review all the procedures, all the figures, and the terminology in that chapter. All right, any questions over anything before we go?
No.
All right, very good. All right, guys, we'll have